seen me kind of just shift my view back and forth. But thank you so much for holding out. It's really nice to meet everybody. I'm Dr. Velez. I'm a urologist here at Robert Wood Johnson and the Cancer Institute. And tonight we're going to talk about fertility preservation and options for men with a history of cancer. I think I always like to take a step back and frame why we talk about this. And it's because a lot of people are surviving their cancer diagnoses. The 5-year survival rates in men ages 20, over 20, over 45 is really over 75 to 85%. So that's incredible, right? So you get a very scary diagnosis, but there's a lot of hope that things are going to get better. But the bad news is that we are seeing a rising incidence of all cancer diagnoses in those who are younger than 65, which to me is really that population that's still considering their fertility potential. Here at CINJ, so a couple of years ago, I pulled these numbers, and what we were seeing was that over 500 new oncology patients up to the age of 55, and 138 of those patients were really squarely within their reproductive years at ages 16 to 35. And I think that can be one of the greatest challenges is that, when you're young and the last thing you're expecting is a cancer diagnosis, and you get that diagnosis, suddenly being able to, talk about fertility and the possibilities for future, even though it can be a very hopeful conversation, a lot of times patients are just so overwhelmed that it feels like a road closed, and, it's hard to really take in that information. And so that's why I really like talks like this, because I think it's an opportunity to sort of sit down and really take in a bunch of information, hopefully in a less stressful time when you have the opportunity to let it just sort of sink in. The reason why I really harp on patients talking about fertility preservation instead of recovery is because we see a lot of patients who unfortunately didn't get this opportunity, or maybe they were too overwhelmed at the time of their diagnosis to really consider their options. And they jump into their therapies like surgery or sometimes radiation. Sometimes they get lots of different types of chemotherapy, just like this one case example. This was a 36-year-old patient of mine who had a history of testicular cancer. He was 33 when he was diagnosed. He got a lot of chemotherapy and then was coming back to see me because he had a recurrence, and they were thinking about radiation, and they now wanted to see if there's anything they could possibly save. So in standard fashion, we had him go get blood work, we had him do a semen analysis, and unfortunately that semen analysis came back azoospermic, or no sperm within the ejaculate, probably because of his history of the chemotherapy. So we'll close the loop later at the end of the talk about what we ended up doing for him, but this puts us in a tricky position, because if there's no sperm is basically the cell that men need to be able to reproduce, then we don't have an option for biological children at that point. Taking a really, 2 steps back, a quick primer on how sperm is made. If you look here at this picture in the left side of the screen, you see that this is a cross-section of the testicle. And the testicle is really made up of thousands of coiled tubes called seminiferous tubules. If you look at a cross-section of a single tubule, which is that purple image, you can see that there's these dark purple circles on the outer periphery, and then as you work your way closer into the lumen, they get lighter and lighter. Those dark purple circles are actually the germ cells. So these are cells that replicate, and they'll divide into an A and a B cell, and the A basically replenishes that source of germ cells, while the B cells are the ones that undergo meiosis and eventually form mature sperm. So as you're moving farther and farther, like closer and closer in towards the lumen of that tube, you're getting more and more mature sperm. Sperm store within the epididymis, which is this like mohawk of a gland that lives on the back portion of the testicle. And that's really where they learn how to swim. And that's where they'll live until you ejaculate. And with ejaculation, sperm are forced through the vas deferens and then out into the urethra as part of the ejaculatory fluid. And that whole process of sperm production or spermatogenesis takes about 74 days. So we round up to about 3 months. Germ cells are crucial for future fertility in the cancer patient. So we know that chemotherapy, radiation therapy, they're going to attack some of the most rapidly dividing cells in the body, which on one hand are tumors, but on the other hand are also sperm. So Unfortunately, even though if the sperm cells are taken out, if we're able to protect those germ cells, then that patient has the potential for fertility in the future. But we know that certain doses of chemotherapy, certain doses of radiation therapy can also wipe out those germ cells, which is where we get nervous about permanent infertility for that patient. There are a lot of other things that happen, though, with a cancer diagnosis that can affect fertility. So changes to the testosterone or the hypothalamic pituitary gonadal axis, that changes hormones. And that HPG axis disruption can decrease how much testosterone is available to support sperm production. Testosterone is also needed for having a healthy sex life, for having good erections, good sex drive, being able to have orgasms, so that it's not just about fertility where we can see those changes. Certainly, surgery can change our ability to make sperm, especially if you lose a testicle or both testicles. Or sometimes surgery within the pelvis can change our ability to have healthy erections or being able to ejaculate in a forward fashion. And then finally, the other sequelae that can show up from a cancer diagnosis can include fevers, malnutrition, stress, inflammation. All of these things also contribute to poor sperm production. I always like to say there is no low-risk chemotherapy option. So there are certainly different types of chemos, there are different combinations of chemos, and that combination factor makes it really difficult to study this because oftentimes our studies are done in a vacuum. We know that if patients just got vincristine or just got mercaptopurine, then we typically will see a 60%, we'll see a drop in sperm production, but that about 60% of patients should start to see recovery of that sperm count around the 6-month period. Other cycles like ABVD and BEP, which we typically would give for testicular cancer, 30 to 40% of patients are going to have low sperm production or no sperm production immediately. But usually with time, we see some recovery of sperm production. So about 80% will start to see some sperm in the ejaculate around the 8 to 10-year mark. Cisplatin and other platinum-based chemotherapies, 1 in 4 to 1 in 5 patients are going to be permanently azoospermic or not be able to produce sperm 15 to 20 years later. And finally, agents like cyclophosphamide, busulfan, ifosfamide, CHOP protocols. These are some of the heaviest hitting chemotherapy combinations that we see. And they're the ones that are most likely to render patients permanently azoospermic, or in other words, take out those germ cells so that we're not able to produce sperm in the future. Alkylating agents used in combination with other chemotherapies are thought to have an additive adverse effect. So again, it's difficult to study this when we have patients who are getting multiple different combinations of chemotherapy. So, that my biggest take-home point, I think, from the slide, without getting lost in all the numbers, is that unless we get a baseline semen analysis, we don't know who has sperm production at baseline. So everyone getting chemotherapy or even radiation therapy is going to get some hit to their testicles. And even though you might get some recovery, we don't know how much recovery you could possibly have if your baseline is already not good. So with all that uncertainty, we really like to push testing and also freezing from the get-go before any kind of chemotherapy or radiation exposure, because that truly is the greatest insurance policy for our patients. Radiation can also impact spermatogenesis. Even though we try to do as much shielding as possible, there's always going to be some scatter of radiation inside the pelvis, inside the testes, and that can still result in spermatotoxicity or damage to the sperm production. We know that patients who receive more than 3 grades of radiation are at a very high risk of having permanent azoospermia or permanent infertility, and receiving higher doses, so in the 20 to 30 range, can result in poor testosterone production. So very common for my patients when they come to see me to talk about this to at least get a testosterone level so we can just see what the numbers are. And that opens up our door to being able to talk about, testosterone supplementation if needed for patients. The ASRM, which is the oh my gosh, I can't remember, American Society for Reproductive Medicine and ASCO have joint recommendations that conception is not attempted with freshly ejaculated or even extracted sperm within 1 year of the last chemotherapy or radiation dose. And that's really because that chemotherapy and radiation are, as we saw here, really attacking the sperm production cells. So any sperm that's being produced at this time point within that 1 year of treatment are thought to have some kind of abnormal DNA underlying the cell, with a higher risk of some of a congenital abnormality in offspring. So our recommendation is always for that 1 year, use contraception and do what you can to prevent a conceived pregnancy. We get that recommendation based off of this study from Sweden. So this was a population-based Swedish study where they looked at the rate of congenital abnormalities in children, and they found that there was a slightly higher rate for any children conceived naturally within 1 to 2 years of a chemotherapy or radiation exposure to the parent, to the father. Most of those defects went away, or most of the higher prevalence of those defects went away after 2 years of the cancer diagnosis, which is, we think that at that point, the sperm is given enough time to recover, and any sperm aneuploidy or DNA damage decreases back to baseline levels. So that's really where we get that 1 to 2 year recommendation to wait to conceive. ASCO also recommends that male cancer patients be counseled regarding contributing factors for infertility surrounding their diagnosis as early as possible in the treatment process. And I think that's really because even though it doesn't take a long time to actually do the actual, like the banking and the fertility preservation piece, there are some logistics that have to go into place to get that done. So better for patients to deal with it and get it out of the way and then move on with the rest of their diagnostics and treatment. In sort of a more stress-free scenario. Unfortunately, though, despite that recommendation that we do this and we offer it early on, when you ask patients, that recommendation doesn't always pan out. Looking at patients' perspective and in retrospective, interviews with cancer patients, they found that of 900 men with cancer, only 51% recall being informed about fertility issues and being offered sperm banking. So whether or not that, 100% were offered and maybe only 50% remembered because they were so overwhelmed by their cancer diagnosis, it's hard to say. But I think ultimately the depressing part to this to me is that 77% of those men reported wanting children after their cancer treatment. But unfortunately, only 24% actually banked sperm. So, this is a really big step off between having the opportunity and the possibility, but actually going through and doing it and having that insurance policy. When we look at the live birth rates, we've looked at sibling data. So siblings who are survivors of cancer are in the red. And if you compare that to siblings who didn't have cancer, but technically the same gene pool, you see that there's a much higher pregnancy rate in the blue and even live birth rate in the blue compared to the red. So in other words, cancer patients are, even though they may want children, are less likely than their siblings to have a pregnancy or a live birth. And that's probably because of their chemotherapy and radiation exposures taking away that opportunity for them. This is really a graphical representation of survivors and parents. So, children with cancer, and then what their parents are remembering from those initial conversations of the diagnosis and the planning for the future. And you can see that really of the themes that come out in the conversations, regret comes up on both sides in those bright, big letters for survivors and for parents. And other themes that come out are, in the survivors, feeling like there was a survival trade-off, or worrying about like these are late effects that maybe we can't deal with right now. We're too young to care. Fear of dying, being too young to be involved. These are common things that come out, but I think still should be addressed in conversations as early as possible, because it just buys us more time to deal with those feelings and be able to make the right decision for that patient and help parents to help make that decision for their children. Ultimately, fertility is an essential component of survivorship, and our patients often don't know to ask for it or how to ask for it. And by the time they figure it out, sometimes it can be too late, because once patients get exposed to that chemotherapy or that radiation therapy, we have to wait that full year before we can safely retrieve that sperm. at which point they may not be able to make it. Here at the Cancer Institute, our general pathway is once patients are diagnosed, if they are interested in fertility preservation or even just having a conversation about what that would look like and the risks and the benefits, we really recommend that they reach out to us so that we can get them in quickly. If patients are admitted to the hospital, they can call us for a urology consult. My inpatient residents can certainly field this consult and help facilitate. I'll come by and see them. Versus as an outpatient, patients can always call the OAC or Oncology Access Center and ask for an urgent appointment with myself. I'm at the Cancer Center every Monday, and we purposely hold appointments open for patients for this very specific reason, because we know you're on an urgent timeline. In general, the protocol that I think about is, first, how old is that patient? Patients over the age of 15 are likely to make sperm, so reasonable to try to have them ejaculate if possible. So if they can't ejaculate, and they're over the age of 15, then we have other options. So we can give them medication sometimes to force the ejaculate forward. We can do vibratory stimulation, or we can even plan for a minor procedure called a TESE, where we make a very small incision in the scrotum and then take out little tubes of sperm and send that to the lab for processing. Believe it or not, we've done this at the bedside in the hospital with really, really good blocks, where patients basically feel a pinch and some pressure. Or we can do it in the operating room under general anesthesia, and it really takes us about 15 to 20 minutes to be done. If the patient can ejaculate, though, then this is the easiest option for everybody. We basically will send the patient to a fertility lab. There's a couple in the state, and they'll schedule an appointment to masturbate, ejaculate, and then hand that specimen over to a lab technician. If we see sperm in the ejaculate, we'll freeze it. And ideally, our goal is to get 8 to 10 vials of frozen sperms in order to say that, this is a reasonable insurance policy for fertility preservation. If there's no sperm in the ejaculate, so let's say that all the sequelae of cancer, even before you've gotten treatment, is taking its toll on the testicle, and then the sperm production is already zero. Those are patients where we'll plan to go to the operating room and perform something called a micro-TESE, which takes a little bit longer. It is done under general anesthesia, and we're basically using a microscope to really examine little microscopic pockets of the testicle for areas of sperm production. In this setting, this is where I think knowing earlier is better, because it takes a little bit of time to coordinate this. And sometimes we can even coordinate a micro-TESE to happen at the same time as like a port placement or a bone marrow biopsy. And that might save you an anesthetic, an extra episode of anesthesia. So knowing sooner gives us more flexibility for planning. We're just on ideal number of vials. I mean, where do we get the 8 to 10 from? The answer is there isn't a great science behind it. We just know that once a vial is thawed, they can't be refrozen. So, in the future, when you're ready to use those vials for fertility, depending on how much sperm was in that vial is how we'll sort of say, should we try for IUI versus IVF to be able to conceive a biological child. IUI is the easier form for the female partner. It's intrauterine insemination, but really requires a minimum of like 10 to 15 million swimming sperm in that vial to garner like the highest rates of success for pregnancy. Versus IVF, where we really just need as many sperm as eggs. So unfortunately, even though it's more invasive and more intensive for the female partner, for some patients where if we look in and we're like, look, there's just not a lot of sperm here, you don't have many vials, we may recommend IVF from the get-go, because you'll just get a lot more utility out of the vials, and more likely to get embryos that are going to be able to allow that patient to build the family that they're looking for. So ideally 8 to 10 is mostly our industry standard, which may mean that the patient needs to go a couple of times, so timing considerations are important. Unfortunately, here at Robert Wood, we don't have an andrology lab, so most patients are going to go to an outside lab. RMA is very common. The Sperm and Embryo Bank of New Jersey is also a very common option. And patients are usually calling that lab to set up an appointment to really make sure that there's a lab tech available to receive and then immediately process the specimen. Most labs will offer this early in the mornings from like 6 a.m. to lunchtime. Specimens should be processed within 1 hour of ejaculation. That's really to prevent any loss of sperm in transit. And if there are very low sperm counts, patients may need more attempts and thus more time before starting treatment. We also always want to account for the fact that some sperm is going to die during the freeze and the thawing process. And to optimize the amount of sperm that we get, we will really like patients to space their ejaculations at least 1 or 2 days apart. So that, again, might require 2 to 5 attempts. So every 1 to 2 days might take somewhere between 5 and 10 days to fully freeze enough that we feel safe moving forward with treatments. There's also now an online option. So Fellow is a really great online lab. Well, the lab is based out of the University of California in San Francisco, which is a world-class state-of-the-art lab. But what they've really perfected is the cryopreservation medium. So patients can go online and purchase kits. They're mailed directly to their home. It costs about $200 for the freezing and processing, and then $140 a year after that for storage. We also have these kits available at the Cancer Institute and in the clinical academic building if patients want to pick it up in person. But this is a really nice option where it's a little bit more private. You can do everything from the comfort of your home and then just plan for overnight mailing back through UPS to the lab at San Francisco. And we've also had patients successfully do this while they've been admitted to the hospital if they can't leave to go to the fertility clinics to do their banking. Switching gears a little bit, there are certainly specific considerations and frankly barriers for preservation in our pediatric or our, young adult population. One of them is that it can be a very awkward conversation. The patient may be young enough or the family certainly hasn't thought about parenthood for that child. And having, there's also the long-term costs to consider. Sperm, once it's frozen, needs to stay frozen. Otherwise, it's, once it's thawed, it's no good. Frozen sperm can stay frozen for forever and it'll still be good. It'll still be useful for fertility, but you do need to pay for the storage fee, which depending on the lab, depending on the bank, could be anywhere from $200 to $500 a year. There's also the need for assisted reproductive technologies on the other end. So even though we have sperm, we have to consider about how we're going to use it. And for some of our patients where we're not getting a large number, it's a very small number of sperm, and they are basically committing themselves to IVF. If that's not covered by any insurance, cycles can cost anywhere from $10,000 to $15,000 per cycle. So there is a very long-term cost associated with this. Going back to that initial slide, like, can the patient ejaculate? Are they sexually active? Are they even making sperm? We know that patients who are 11, 12, 13, high rates of azoospermia. So you can see this bottom bar, the ages of 11, 12, 13, 14 up to adulthood. And the prevalence of azoospermia is very high. So not even being tested in the 11-year-olds, but in 12-year-olds, the earliest patient we think patients are really going to be able to ejaculate, 65% of those patients are not going to make sperm. So is it even worth it to put them through the stress of having them ejaculate to check? That number seems like it improves at age 13. 14 and 15 is where we're seeing a prevalence of about 10% for azoospermia, but it's really not until about 16 years of age that we start to see that prevalence of azoospermia drop down to about adult population levels. So in my practice, around 14, 15, depending on that patient's maturity and their Tanner staging for puberty, I may offer them to attempt an ejaculated specimen, but prior to that, I think the rate of failure is too high, and we're usually defaulting more towards surgery. Surgery in that population, so really the under 14 group, is experimental. This is an experimental protocol. It's research that's been spearheaded by the University of Pittsburgh. It is IRB approved here in Robert Wood. We're one of, I think, 35 sites now that are offering tissue into this protocol. Effectively, it means a wedge biopsy of the testicle. So it's a small incision. We're taking a very small volume out. That patient shouldn't miss that testicle piece. But the lab is really looking for those stem cells. So these are the germ cells that eventually will mature to be able to produce sperm, but in that moment probably isn't because of the patient's pubertal status. With the IRB and with the protocol, 25% of the tissue gets dedicated for research, meaning that it's de-identified, so nobody knows where it came from. But 75% of the tissue gets frozen for the patient's future use. So it's identified, they're able to access it, and in the future, we hope that the technology will catch up so that we're able to develop that tissue and transplant it back into the patient well after they've finished their chemotherapy and their radiation therapy so that they can recover their natural sperm production. This has been proven in monkeys. So it started with 5 prepubertal rhesus macaque monkeys. These were animals that did not produce sperm. And they basically took samples of tissue, which you can see in the A slide, and then they ablated that monkey with I think with busulfan. So they gave them high levels of chemotherapy that rendered that monkey permanently azospermic or not producing any sperm. They then took that testicular tissue, they treated it, and they implanted it back into the monkey's, I think, belly and back. And then they gave different hormones to stimulate that tissue. And these are different protocols where they went back in after 6 months, after 8 to 12 months, and they were actually able to recover sperm from every single one of the grafting sites, which you can see here in this D picture. That little inset is a picture of a sperm, a mature sperm. They then used that sperm for IVF with a female monkey, and so many months later, Grady was born. He's a very special rhesus monkey. It's appropriately named for how she came in because Grady stands for graft-derived baby. And now Grady is, what is that? She's 7 years old. And in my last talk with Dr. Orwig, she says that she is healthy and normal. Taking that a step further this year, that same lab, Dr. Orwig's lab, basically went back to one of his research patients. This was now an adult, a 21-year-old adult, who originally had undergone this research protocol when he was peripubertal, so I think around 12, 13 years of age. He was diagnosed with an osteosarcoma of the femur. And this patient had actually already received some chemotherapy, but at that point, they biopsied the testicle, froze the germ cells, and is now coming back in as a young adult in his 20s with permanent azospermia. And they've now thawed that tissue, identified the stem cells, and injected it back into his testicle under ultrasound guidance. So at this point now, we're just waiting to see if that tissue takes and if we're able to generate sperm from that patient. There was an interesting news article, though, where the patient he had an interview, and I like this screen grab because he said that, and this is in the blue box, even if his experimental transplant didn't work, he's hoping it will guide future research. And he expressed gratitude to his parents years ago for making a call that gave me the option to make the choice for myself today. So, I think that it's always a really difficult conversation for parents to make this choice of undergoing another procedure for their child. But I do think that in some cases, it is the only option for patients, and it provides them hope for the future and at least gives them the ability to make a choice. So for the patients who don't preserve prior to their cancer treatments, just like our initial index case of the guy with the testicular cancer who was azospermic, we do still treat those patients. I routinely see these guys as well. We do have options, but it's just lower success rates. So, typically we would get baseline hormonal labs to see what their testosterone is, and we would also get that semen analysis to see what their sperm production is at that point. If they're azospermic, we offer microtesting. But it should be noted that, success rates are really lower. 37% is what's described in the literature versus 40 to 60% of patients who need a microtesting, but not because they had chemotherapy or radiation therapy. We see lower fertilization rates and lower clinical pregnancy rates as well, really just 50-50. And I think that's really because the quality of the sperm at that point is just lower. So we have a lower ability to fertilize, therefore lower embryos and fewer pregnancies and live births. Okay. So again, going back to it's not that patients don't have any options, but we have more options, more of an insurance policy if we're able to freeze prior to receiving any kind of treatment. Finally, just a quick plug that sexual health is really important for survivorship as well. As a reproductive urologist, half my hat is on sperm and fertility, but the other half is really the rest of sexual health. So testosterone and erectile function, orgasm, ejaculatory function, penile length maintenance. These are all things that can be affected by aging and chemo and radiation, surgery, low testosterone. And they're important parts of survivorship. So if it's something that you're concerned about, that you're experiencing, come on down. You know, we see patients in the clinical academic building. I see them at the CINJ every Monday. You can always call any of these numbers or send me an email and we can facilitate an appointment for you. So thank you again for coming, and I'm sorry if we got started late, but I'm happy to take any questions at this point.
Thank you, Dr. Velez, for a great presentation. We do have a few questions in the chat, so I'll just read them out for you. So the first question is, can prostate cancer patients on hormone therapy come off of medication for several months and have sperm production resume?
They can, yes. So with the hormonal therapy from prostate cancer, it's basically knocking out all of the testosterone. And testosterone is a necessary hormone to make sperm. So many times patients won't make any sperm while they're on the ADT or the hormonal treatments. It takes a while for the testosterone to come back. So on average, depending on how long you've been on it for, it could take anywhere from like 6 to 24 months for really to get that that testosterone recovery. And then it's usually an additional 4 to 9 months after the testosterone recovers to be able to turn the sperm production back on. So it's a long haul. Yeah. I have seen some studies of patients with prostate cancer who have been on hormone therapy going for microtesty, so for surgery. And we see a little bit more success there in finding like tiny little pockets of sperm production and using that. But again, you know, that is sperm that has to be used for IVF. So it limits the utility of it.
Thank you for that. So the next question we have in the chat is, does sperm production decrease as you get older, for example, 59 years old?
It does, although, you know, honestly, it's not the same as like women with our fertility potential really coming down quickly after around 35 to 38 years of age. We see a steady decline in sperm production as men get older. I think more concerning is that we also see a steady increase in abnormalities in the sperm. So nothing that can really be tested well, but we certainly see higher rates of autism and congenital abnormalities and schizophrenia, metabolic syndromes in offspring for parents in children whose dads are over the age of 45 when they were conceived.
One other question we had that came in the chat is, how do female patients at the Cancer Institute get an appointment for their fertility appointment?
It's an excellent question, something that we've been really working on. So right now, we don't have a reproductive endocrinologist on staff at the Cancer Institute or Robert Wood Johnson to address this, but we do have community ones who are very dedicated to female fertility preservation and getting you in quickly. Most of the time, the cancer navigators are reaching out to me just for that contact. And I certainly I work with them all the time on cancer or not cancer patients. So, you know, it's very easy for me to reach out to say, hey, I've got this patient, they need to get in tomorrow. Can you see them? And that's something that we're very happy to help facilitate. But
Thank you.
it is trickier. I mean, we're men, you hopefully are producing millions of sperm a day. So we tap into that through, you know, ejaculation or for a surgery, we can usually freeze it right away versus women where we're really only giving up 1 egg a month if we're lucky, right? So it takes somewhere between 7 and sometimes 21 days to do the IVF cycles to stimulate to produce multiple eggs so that you can harvest and freeze. That's a little bit more of a time crunch.
Thank you for that. The next question I had is, can you talk a little bit more about the insurance process when it comes to kind of all of the kind of stuff that you do?
Yeah, so I would say that it's very variable, which is the most frustrating thing on the planet. There was a change in insurance cover, a state mandated insurance coverage for fertility. So semen analyses and processing of sperm should have some insurance coverage at this point. Storage is not covered by the insurance. Okay, so that annual fee to keep everything frozen and healthy is not covered by insurance. There are certainly labs in the state that offer discounted programs. So for example, RMA at Basking Ridge and at Eatontown, those are their two lab sites that offer freezing. Will usually charge about $400 to process and analyze, process, and freeze sperm for 5 years, which thus far has been the cheapest that I've seen. I have certainly seen some patients pay that fee up front and then submit to their insurance on the back end because sometimes they don't have the time to wait for prior authorizations. I don't know, I'm not aware of any grant funding at this point through CINJ to help cover that cost. But as far as I know, that's been the cheapest that I've seen so far.
Good to know. Thank you for answering that question. Now the last question I have from the chat is, I just lost it. Sorry, it was a private message. Oh, okay, here we go. So the last question I have is, are there any healthy lifestyle changes that you can make to improve your sperm count?
For sure. So, I think smoking, alcohol use, marijuana use, all of those things have been shown to really decrease the production of sperm and also the quality of the sperm. Having a healthier lifestyle is always going to be better for sperm production, and not only for production, but also like offspring. So we know that dads who focus on like exercise, like weightlifting, high intensity interval training, cardio, eating healthy diets, like Mediterranean style of eating and cooking, they tend to be in better health and their children tend to be in better health. So it's not just for you, it's also for your offspring down the line. But those are things that take time. And, I know that's usually sometimes the hardest thing to do is just to commit to that day in and day out.
So those were all the questions that I had from the chat, whether it was public or private. So now I just want to open up the floor. If anyone had any last minute questions for Dr. Velez, you can unmute yourself to ask a question or place it in the chat. And you can also send me an email afterwards if you feel more comfortable asking the question offline. So I'll give it a few minutes if anyone had any additional questions for Dr. Velez. I see earlier in the chat, someone did ask if the recording will be available. We do post this on our website. So in about 2 days, it should be uploaded to our website so you can review the material that was presented. But once again, I just want to thank Dr. Velez for joining in for the very informative and really engaging talk that you had. And thank you everyone for attending today.
Thanks, everybody. Have a great night.
Have a great night, everyone. Thank you.
Take care.